Hi everyone. Peer Medical Foundation is a youth-led volunteer international not-for-profit organization advancing health equity, diversity, inclusivity, and racial justice in medicine. We welcome our first introductory workshop addressing Islamophobia in medicine series, which will explore the challenges faced by Muslim patients and healthcare professionals and discuss actionable steps to create a more inclusive and equitable medical environment. We also have our wonderful guest speaker here, Dr. Khan, who has been active in mentoring medical students from McMaster University as an advisor and clinical instructor. She has also been a community member of the University of Guelph Multi-Faith Committee, and she has been active with Guelph Syrian Refugee Settlement Program. We are excited to have her here with us today. Next, we will be beginning our workshop, and I want to quickly do some housekeeping things. We will start with the land acknowledgement. We would like to acknowledge that Peer Medical Foundation is situated on the traditional, ancestral, and ceded lands of the Haudenosaunee Confederacy, and more specifically on the lands of Mohawks. The colonizers that initially settled here on indigenous land committed acts of genocide and ethnic cleansing as they stole the land of the Haudenosaunee and other indigenous peoples across Canada, and the Canadian government continues to commit the genocide today. More broadly, we want to acknowledge that the people attending this workshop are meeting across all 11 treaty territories in Canada. The Peer Medical Foundation is dedicated to doing its part, facilitate the healing of Indigenous peoples and communities across Canada, as well as achievement of health equity for Indigenous peoples, and encourage everybody attending this workshop to reflect the past and present circumstances of Indigenous peoples, as well as what we can each do to help these communities. Next, I will touch upon the diversity, equity, and inclusion statement. We are dedicated to forwarding the goals of inclusivity, diversity, and racial justice in medicine. We strive to foster the environment of inclusivity for historically underrepresented groups and firmly believe that it's our responsibility as future and current healthcare professionals to create a safe space for people and patients from different backgrounds. We have a zero-tolerance policy towards racist, homophobic, transphobic, and sexist attitudes and other discriminatory behaviors. Through this workshop, we hope to provide a safe space for diverse voices to be heard, educated, and empowered. Lastly, I want to cover some of our ground rules, that this is a safe and open space for you to share or not to share your thoughts, feelings, and experiences. Negative, hurtful, or discriminatory comments will not be tolerated. You can always choose to pass if you're not comfortable speaking. Okay, so to give you an overview of what will be covered in our first part of the series, which introduces us to the topic of Islamophobia and its relevance in medical context, which will be followed by a session from our wonderful guest speaker and an interactive Q&A session at the end, should there be participants willing to ask the questions and the guest speaker willing to answer the questions. Okay, given that, we will begin with defining Islamophobia, and our wonderful Assistant Director of Education, Fatima, will give us an introduction to Islamophobia and its context in medicine.
Thank you so much, Ritika. So basically, what is Islamophobia? So Islamophobia is ultimately an irrational fear, aversion, or discrimination against Islam or Muslims. It is rooted in stereotypes and misinformation, leading to prejudice and hostility towards people who are perceived to be Muslim, regardless of their actual beliefs or practices. So components of Islamophobia include irrational fear. And so irrational fear is a baseless and disproportionate fear of Islam or Muslims. And this fear often stems from ignorance, lack of exposure, or media portrayals that associate Islam with extremism or violence. Another component as well would be aversion. Aversion is a strong dislike or hatred towards Islam or Muslims, and this aversion can manifest in attitudes, behaviors, or policies that seek to exclude or marginalize Muslims. Another component as well would be discrimination. So, discrimination is in unjust or prejudicial treatment of Muslims, which can occur at an individual, institutional, or societal level. And discrimination can be direct, such as denying someone a job because they're a Muslim, or indirect, like implementing policies that disproportionately affect Muslims. And so now we'll be moving on to the second part, which is forms of Islamophobia. So, Islamophobia can really manifest in various ways. This could be ranging from subtle biases to overt discrimination. And so it is important to recognize these different forms to understand the full scope of the issue. So when I say subtle biases, this can be like microaggressions. So everyday verbal or nonverbal slights or insults that intentionally or unintentionally convey derogatory messages to Muslims. Examples of this could include questioning a Muslim's loyalty to their country or expressing surprise at their proficiency in English. Another possible aspect could also be cultural stereotyping. So, this could be assumptions that all Muslims share the same beliefs, practices, or cultural traits. And this is often based on negative stereotypes. So, for instance, this could be assuming that all Muslim women are oppressed or that all Muslim men are violent. And those would be some examples. Or stereotypes that affect understanding, actions, and decisions. So, even individuals who believe in equality may harbor implicit biases that lead them to treat Muslims differently. Also, we would also like to cover overt discrimination. So, this could be hate crimes. Like, hate crimes are ultimately acts of violence or intimidation specifically targeting Muslims because of their religion. And this could include physical assaults, vandalism of mosques, or threats. And institutional discrimination, which is ultimately policies or practices within organizations or institutions that disadvantage Muslims. So, examples could include discriminatory laws, profiling by law enforcement, or barriers to employment and education. Finally, another possible aspect as well would be political Islamophobia. So, this would be the use of anti Muslim rhetoric or policies by political leaders or parties to gain support or marginalize Muslim communities. And this could include bans on religious attire, restrictions on building mosques, or surveillance of Muslim communities. So, now with that being said, we would also like to cover the prevalence of Islamophobia both on a global and Canadian context. So, when it comes to global statistics and incidents, there have been a lot of rising hate crimes. So, when we say this, we mean that in many Western countries, there has been a significant rise in hate crimes against Muslims, particularly after major terrorist attacks. For instance, in the United States, hate crimes against Muslims increased by 67% in 2015 following the San Bernardino shooting. Equally, anti Muslim legislation, so countries like France and Switzerland have passed laws banning certain Islamic practices, such as wearing the niqab or building minarets under the guise of secularism or national security. And also, another aspect is even surveillance and profiling. So, Muslims are often disproportionately targeted by counterterrorism measures, leading to profiling and surveillance. And this is particularly evident in policies like the USA Patriot Act or the UK's Prevent strategy. So now when it comes to Canadian statistics and incidents, so again, there have been hate crimes here as well. It would be Statistics Canada reported a 151% increase in police reported hate crimes against Muslims from 2016 to 2017, and the Quebec City mosque shooting in 2017, where 6 worship and widely criticized for disproportionately affecting Muslim women who wear the niqab. Likewise, there's equally employment discrimination. So, employment discrimination includes the fact that studies have shown that Muslims in Canada face higher rates of unemployment and underemployment compared to non Muslims, even when they have similar qualifications. So, a 2011 study by the Canadian Labour Congress found that Muslim women are 3 times more likely to face employment discrimination. So now that takes us to the next slide, which is Islamophobia in a medical context. So here we will be covering a wide variety of topics, specifically beginning with manifestations of Islamophobia in healthcare settings. So Islamophobia can impact healthcare settings in various ways. This could affect both patient care and the working environment for healthcare professionals. So when it comes to patient care, there has been, discrimination in treatment has been noted. Specifically, Muslim patients may experience biased treatment or care based on their religion, and this can include negative assumptions about their health behaviors, such as dietary practices during Ramadan, or stereotypes about their health risks. Again, another aspect as well would be cultural insensitivity. So, healthcare providers might lack cultural competence, which could lead to misunderstandings or insensitivity towards Islamic practices. So, for example, failure to provide halal options in hospital food services, or not accommodating prayer needs as well would be some examples. Likewise, there are equally barriers to care. So Muslim patients may face barriers to accessing care due to systemic barriers or discriminatory practices, including difficulties in finding providers who respect their religious needs or language barriers. Likewise, another aspect is also staffing. So, as we mentioned, we talked about workplace discrimination, but ultimately, Muslim healthcare providers might face biases in hiring, promotions, or daily interactions, and they may also experience microaggressions or overt hostility from colleagues or patients. And another aspect of this would be dress code policies. So, there are often policies that restrict religious attire, such as hijabs or beards, which can disproportionately affect Muslim staff. And this can lead to exclusion from certain roles or affect job satisfaction and performance. So all of them are really so would be policies. So this would be institutional bias or policies or practices that do not account for religious needs and can contribute to a discriminatory environment. For example, rigid scheduling that does not accommodate religious observances, or lack of prayer facilities in workplaces are all some examples. So now when it comes to the specific challenges, that are faced by Muslim patients and healthcare providers. So we will be covering that in more detail too. Ultimately, challenges for Muslim patients include cultural misunderstandings. So Muslim patients may encounter healthcare providers who do not understand their cultural or religious practices, leading to discomfort or inadequate care. For example, misconceptions about fasting during Ramadan, or this could lead to inappropriate dietary recommendations, or medical advice, all aspects that would ultimately again lead to that discomfort or inadequate care. Likewise, privacy and respect would also be another challenge. So again, this would be issues of privacy and respect, which would be compromised, if healthcare settings do not adequately address religious or gender-related needs, such as the presence of opposite gender healthcare providers during examinations. Likewise, another challenge would be fear of stigmatization. because Muslim patients may fear being stigmatized or judged due to their religion, which can discourage them from seeking the necessary medical care that they need, which would again be a hindrance. So now, when it comes to that, so again, we explored the challenges for the patients, and so now we'd like to also look at the challenges that Muslim healthcare providers also face at the same time. So this would specifically be workplace harassment is a really big one. Muslim professionals may experience harassment or discrimination from patients or colleagues, which could impact their job satisfaction and their mental health at the same time. Equally, religious accommodation, because difficulty in balancing religious practices with workplace requirements can ultimately create stress. And this includes finding time for prayer, adhering to dress codes, and managing fasting during Ramadan. Likewise, professional advancement. So, professional advancement, what we mean here is that this could include bias in evaluations or promotions, which can ultimately hinder career progression for Muslim healthcare workers, and it could thereby and a representation in the field. So again, all of these factors, as we've explored from both the patient side and the provider side, could be taking place at the same time or isolated depending on the situation, but they ultimately are challenges in either case. Likewise, so then this leads us to exploring some case studies and research findings. So firstly, when it comes to the first case study, so this would be discrimination in patient care, we'd specifically like to mention a study, like a 2018 study that was published in the Journal of General Internal Medicine. And it found that Muslim patients in the US reported higher rates of perceived discrimination in healthcare settings, including instances of being treated unfairly or with less respect compared to non-Muslim patients. Similarly, another case study, which specifically covered workplace bias against Muslim healthcare workers, it really demonstrated a similar finding. So, research published in Social Science and Medicine in 2019 highlighted that Muslim healthcare professionals in the UK reported facing discrimination related to their religious attire and practices, which affected their job satisfaction and professional interactions as well. Finally, another case study which demonstrated the impact of cultural insensitivity. This was a 2020 study in health affairs, examined how cultural insensitivity in healthcare settings led to poorer health outcomes among Muslim patients, which thereby emphasized the need for improved cultural competence among healthcare providers. So these are all case studies which truly demonstrate discrimination in patient care, workplace bias within healthcare workers, and the impact of cultural insensitivity. And with that, I'll be passing it back over to our wonderful Director of Education, Satrithika. Thank
Thank you
you.
very much, Fatima, and thank you for all the information that you have provided. Next, I have a very striking information that I quickly wanted to dismantle the gendered Islamophobia in Canada as well. So this was extracted from the report from Dr. Khan et al. It mentioned that gendered Islamophobia is prevalent in Canada and is premised on the stereotype that Muslim women are powerless victims of their religious tradition. Visibly identifiable Muslim women in healthcare professions are affected by gendered Islamophobia in the form of exclusion and discrimination, which can result in lack of safety, fear, decreased job satisfaction, and burnout. Education about Islamophobia and gendered Islamophobia should be incorporated within existing anti-oppression and transformative learning teaching practices in medical education. Research and stronger institutional policies and practices are needed to mitigate the harmful impact of gendered Islamophobia on Muslim women in medical spaces. So from here, we will be moving on strategies for change. Although the strategies for change will be the highlight of upcoming workshops, I do want to highlight some important ways we can tackle Islamophobia in medicine, just as a brief introduction to what we will be focusing on in our next workshops from the series. So I wanted to break it down by looking at personal strategies, institutional strategies, and some of the examples of effective interventions on the programs. So in terms of personal strategies, we could be looking into education and awareness. So encouraging healthcare professionals to engage in cultural competence, training to better understand and respect Islamic practices. This includes learning about dietary restrictions, prayer practices, and religious attire. Then we can also focus on self-reflection, promoting self-awareness among healthcare providers to identify and address their own implicit biases. This can involve reflecting on personal attitudes and seeking feedback from peers and patients. Finally, for personal strategies, we could be looking at active listening and having empathy. So fostering an environment where patients feel heard and respected is a very important way to go about some of the personal strategies in tackling this. Practitioners should practice active listening, show empathy, and ask patients about their specific needs related to faith. Next, we will be going into institutional strategies. So some of them including policy changes, so developing and implementing inclusive policies that accommodate the religious needs of both patients and staff. This can include flexible scheduling for prayer times, providing halal food options, and respecting religious attire and dress codes. Cultural competence and training require ongoing training for all healthcare staff to enhance their understanding of different cultural and religious practices and to address Islamophobia specifically. Diverse hiring practices, which promote diversity in hiring to better reflect the patient population and to reduce biases. Having a diverse team can improve cultural sensitivity and patient care. Complaint mechanisms, which can establish clear procedures for reporting and addressing incidents of discrimination or bias, is also an effective institutional strategy. And it ensures that there are safe and confidential ways of patient and staff to raise their concerns. Finally, when we look at some of the examples of effective interventions or programs that are already in place, we look at Toronto's Muslim Health Network, which is a program aimed at improving healthcare access and reducing discrimination for Muslim patients by offering culturally sensitive services and resources. Secondly, we have the Canadian Medical Association's Diversity and Inclusion Initiative, which provides training and resources to healthcare providers to enhance their cultural competence and address biases, including those related to Islamophobia. Again, we are looking into action planning, which is a form that involves creating a structured approach to implementing strategies for addressing Islamophobia in healthcare setting. In this case, it includes setting goals, identifying resources, and establishing timelines. Although this is also a focus of our next workshop series, where we also have an interactive activity that goes along with this in creating action planning for a couple of scenarios as healthcare professionals. I do want to touch upon the basic introduction to this. So steps for action planning in terms of how we can tackle Islamophobia in healthcare setting includes the first one being assess needs. So in this step, we're really evaluating current practices and identify areas where improvements are needed. Then we are moving on to setting goals. So we have defined clear and actionable goals for addressing Islamophobia with the newer setting. This could involve improving cultural competence, revising policies, or increasing diversity. Then we move on to developing a plan. So that is creating a detailed plan outlining specific actions, responsibilities, and timelines for achieving the set goals. And then we move on to implementing and monitoring part of our action planning. So that is really executing the plan that we have devised and regularly monitoring progress to ensure that the strategies are being effectively implemented and adjusted as needed. Then we evaluate and reflect. So this is assessing the impact of strategies and making necessary adjustments. Then we collect the feedback from patients and staff to continually improve and modify the practices as per what's the optimal or the best at hand. While we are doing this action planning, we do want to make sure that we engage participants. So we should encourage participants to reflect on their own experiences and identify specific areas in their setting where they can apply these strategies. And we should also be able to facilitate discussion, which provides opportunities for participants to share their ideas and develop collaborative action plans. So then we are moving on to our guest speaker session with Dr. Khan. We are honored to feature guest speaker Dr. Khan, a seasoned family physician and community leader. Dr. Khan has extensive experience in both medical practice and community advocacy. She has played a pivotal role in mentoring future healthcare professionals. Her insight into the intersection of cultural diversity and healthcare will definitely provide valuable guidance for all attendees. And we are very excited to hear from her, and we are happy to have you here.
Thank you so much, Satu and Fatima, and I'm happy to be here. Yeah, so you guys have covered, you've done an amazing job at identifying, you know, the relevance, the challenges. I think we're all aware that Islamophobia very much exists in the Canadian landscape, unfortunately. It's not new to us. And, you know, we've seen a rise in Islamophobic incidences, as you mentioned, since 9/11, and particularly in the last few years, just, you know, with the Quebec mosque shooting, and then more recently, the London family, the very unfortunate event. And I feel like we've made a lot of strides in our work towards diversity, equity, and inclusion, but we're not touching on the religious piece, right? We talk about all different aspects of diversity, but we're not quite there when we talk about religions, right? So next slide, please. So yeah, so I mean, you've mentioned some of this with Muslims and Islam being the second largest faith in North America, almost approaching 5% of the Canadian population. But with that, we've seen a rise. And interestingly, Fatima, you mentioned 151% increase. I actually came across this really astounding number of 253% increase from 2012 to 2015. That's from Stats Canada. And there's a study done by Environics Environics in 2018 that confirmed this. And they kind of touched on maybe what are some of the reasons behind, you know, Muslims being targeted more than others. And they mentioned that, you know, maybe it has to do with some of the countries they come from. Are these countries associated in the media with, you know, terrorists, certain specific religious practices, such as, you know, wearing a head covering? They were kind of just delving into that, and I thought that was interesting. And then, of course, there was the Angus Reid poll, where they surveyed Canadians as to whether they had a favorable or unfavorable view towards particular religions, including Islam, Christianity, Judaism, Buddhism, Sikhism. And Islam came out at the very bottom. Only 33% of Canadians had a favorable view towards Islam and Muslims. It's very unfortunate, and likely due to, you know, some of the points that you've made earlier in terms of ignorance and lack of education and personal biases and that kind of thing. So out of this have come certain strategies, if you will, as well. Like the first summit on Islamophobia was actually conducted in 2021, where they deemed January 29th a National Day of Action Against Islamophobia. And the first Canadian anti-racism strategy also came out of that. So there's work there's work that's being done in this direction for sure. Next slide, please. But more specific, so I feel like some of that work that I've been involved in is sort of reactionary, as in, okay, let's, you know, fund mosques with more strategies towards safety mechanisms. Let's, you know, cut down on hate speech in social media. But what's really necessary is the grassroots and strategies that address the core causes for this, right? So you'll be aware of the National Council for Canadian Muslims, NCCM. These are grassroots organizations that are not for profit, doing a lot of the advocacy work, so they do it sort of at a community level, at an organizational level, but also at a policy level as well, a sort of political level, if you will, advising and consulting. And even so, I know that NCCM, for instance, they will do workshops for organizations to educate people around Islamophobia and possible biases. The one that I wasn't aware of that I just came across in researching for this talk was the Muslim Advisory Council of Canada. So similarly, not-for-profit organization that does a lot of advisory work. And they actually did a research study in collaboration with McMaster, and I'll go into the details of that study around strategies, causes for Islamophobia and that kind of thing. And it was titled Advancing Equity for Muslim Physicians in the Healthcare Workforce, because it's, we're beginning to recognize that it really is an issue, and it's something that can be addressed at the policy level. So next slide, please. Oh, I really wanted to talk about this. So CPSO, the College of Physicians and Surgeons of Ontario, in their journal, the Dialogue, they actually address this. They call this a public health crisis. And they defined Islamophobia, as you did earlier, that it revolves around an irrational fear, an aversion to or hatred of Muslims. And this may present as Muslim patients feeling dismayed and not taken seriously, I should say, but also it's affecting Muslim physicians in the way that they face discrimination, and they're on the receiving end of racist comments, like things like they feel like they're the other. They've had comments made to them, such as, "I don't trust you. I don't trust your care towards me." So obviously this results in poor mental and physical health, both for the patient as well as the caregiver. Patients and caregivers don't feel comfortable, they don't feel safe in their workplaces. So their sort of comment, the CPSO's comment was, religious discrimination is something we need to talk about in medical education. And this is, like I said, so I didn't actually mention that when I started my medical career back in 1994 at Queen's University, we were told that you leave your values at the door. When you're entering the exam room, you leave your values at the door. And I mean, to me, it was really mind-boggling. It's like leaving your right arm at the door. I mean, you can't do that, right? But we did. But now we're coming full circle and recognizing and realizing that that is not possible. A, it's not possible, and B, it's not helpful, neither for the physician nor for the healthcare worker or the patient. Okay, so next slide, please. Let me just make sure I covered. Yeah, okay. So back to the study that I mentioned that the Muslim Advisory Council had done in collaboration with McMaster. So some of the outcomes from that study, number one, Muslims in particular, but also Muslim women face barriers and discrimination in the Canadian healthcare setting, which results in poor healthcare outcomes. So simple things like not being taken seriously, not being offered all the services that are available. Number two is the lack of Muslim care providers, and that serves as a barrier to for Muslim patients, and particularly Muslim women patients. And number three, of course, and most importantly, that we don't actually have the research or the data to evaluate this, this seriousness of this issue. But so next slide, please. I want to spend a little bit of time on this. I'm just checking the time here. Yeah. The recommendations that they came up with, and they align with a lot of the things that you both touched on earlier. We absolutely need to start including in our DEI work, in our diversity, equity, and inclusion work, we need to start talking about religious diversity, include mandatory training, cultural competency, things like So I'm quite aware now of U of T. They have come up with a handbook to guide and advise and educate and train their staff around simple things like prayer times, fasting in Ramadan, modesty requirements. I remember actually when I was training, when I was doing my surgical rotation, I would be, so everybody else was showing up in scrubs, but I was, having to scramble and look for the gowns that had long sleeves and were long. And it was always a bit of a struggle. And it, always made me feel a bit uncomfortable, but we did it. And now they're incorporating that in their training at U of T, at least. So as you mentioned, cross-gender boundaries, patients and healthcare providers who may not be comfortable with the opposite sex taking care of them. And I remember in my current work scenario, when I had first joined, patients were not allowed to request being seen by a healthcare provider of similar sex. So a female patient was not allowed to request a female physician. Thankfully, we've moved away from that and we've recognized the importance of that, and we do allow that now. But it was it was a long time coming. So dietary requirements. I actually, I had a colleague last week ask me if I could eat, if I was allowed to eat halal pork. So I kid you not, I had to explain to her that no, we don't eat pork at all. But I mean, she was nice enough because she's going out of her way to arrange for a halal meal for me. But just that those kinds of things are still prevalent in our workplaces, and so we need to be able to incorporate annual training. And the thing about seeing things from an equity lens is that it benefits all. Because again, from their report, I came across the fact that not only Muslim healthcare workers, but observing Jews and Sikh healthcare workers are also benefiting from this, right? Like we're all in it together. So item number 2 was to increase representation of Muslims in healthcare, and particularly women. Number 3, medical schools need to adopt a more holistic approach, as I mentioned earlier, like not have this kind of bias that, you walk into the exam room with, you're not a whole person. That just, it doesn't make sense anymore. And number 4, hiring practices that actively involve and encourage Muslim representation. And again, number 5, probably most importantly, more funding and more research is needed for this cause. And I'm realizing, some of the tables where I sit at is that if you don't have the data, nobody's listening to you. So we need to start at the very bottom with gathering, as you mentioned earlier, the experiences and taking those seriously. So next slide, please. Oh, and I just wanted to touch on gender Islamophobia, and as you mentioned, like this particularly pertains to Muslim women, because oftentimes they are, whether it's because of the media or what have you, they're portrayed as powerless victims of their religious traditions. And we know that that's, at least in North America, by far the majority of Muslim women who choose to wear hijab are doing so on their own, right? They're making that choice very much voluntarily. But because they're identifiable Muslims, they are affected more so by Islamophobia in the form of exclusion and discrimination, which results in job dissatisfaction. And I wanted to comment on this article that was published in the CMAJ, the Canadian Medical Association journal, in late 2021, where they had a photo of a girl in hijab, and there was a comment made about the hijab being an instrument of oppression, and that just caused an amazing amount of outroar against, like, right across Canada amongst healthcare workers. And subsequently, within 24 hours, I believe the article was retracted and there was a formal apology made, and they had a list of recommendations from there, very much aligning with what we've been saying. So next slide, please. Yeah, so my advice would be, don't be a bystander. If you are witnessing something that doesn't sit right along the lines of Islamophobia, or honestly, discrimination against any kind of religious or cultural attitude, then don't be a bystander. Say something. Take it. If you're not able to say something to the aggressor, then take it to your lead. And learn about these microaggressions that we've been listening about, that we've been hearing about, comments that can be made, subtle comments, as a result of biases. People are picking up on these things from the media. Ask your Muslim patients how are they feeling? What kinds of care do they need? What kinds, do they need some kind of accommodation in terms of their dress code, or in terms of their, dietary habits? And ask your Muslim colleagues, same thing. If they're fasting, do they need a break? Do they need a safe space for prayer? Ask your Muslim friends. Don't be shy. So I remember very early on, I had a child, actually, I think she must have been 5 or 6, and she asked me if I have hair under my hijab. And I'll be very honest, in my career, and I probably should have mentioned this early on, I have not been on the receiving end of any kind of microaggression. I mean, that comment or that question that, a very innocent young girl asked me is out of curiosity. And I really very much appreciate that. I'd rather that people ask me to my face, and so that there's an option for having that dialogue and having that conversation and clarifying doubts or biases. So I don't see that as microaggression, but obviously it exists out there. So ask your friends, ask your colleagues. And finally, if you're in a lead position, then offer training for your staff on Islamophobia. And I think my final slide was actually about some stats from the US. I didn't include it because we were mainly talking about Canada, but this was very disheartening as well to see this. So the Islamic Medical Association of North America, which is based out of the US, had done a study in 2013. So it was a survey to healthcare workers, and then they compared it in 2021. And so this just outlines some of the rise in Islamophobia, basically. So it went from 20% of healthcare workers facing discrimination to a jump in 2021 to 40%. Particularly Muslim physicians being on the receiving end and feeling that they had been passed over professional advancement. Patients refusing to be taken care of by Muslim healthcare workers, saying, and again, that number jumping from 9% into 2013 to 33% in 2021. So a huge jump. Comments made such as, how do I know you're not ISIS, right? So very troublesome. Physicians leaving their job places due to this kind of discrimination. So again, the numbers jumping from 7% to 35%. And physicians saying things like, I was just not comfortable. It was making me nervous and uncomfortable being in that work scenario, obviously. Yeah, so that brings me to the end of my piece. I don't know if you guys have questions. There's my email, my cell number, if people need to reach out. I'm really, really impressed with the work that you're doing, by the way.
Thank you very much, Dr. Khan. I just wanted to quickly say that while I was listening to your presentation, how much of a stretch you brought our general idea and information to a more real life understanding and your experiences, and really added, a depth of knowledge to our workshop. And I do want to, touch upon a few things you mentioned. I have them written here. You mentioned about the reactionary strategies versus having to tackle more of the core side of things, and some of the organizations that are doing that amazing work. We really appreciate that, and we will definitely look into them for our next workshop, and may even want to contact them and ask any kind of questions we have to them and understand more about those organizations as well. And also, I am on social media as well, so I see a lot of physicians, Muslim female physicians, who tell about the hate words and hateful, we don't trust them type of words, which definitely significantly impact mental health, because as physicians, their work revolves around trust. And if patients don't feel that way, it's both harmful for the physicians themselves and for the patients. And you mentioned about U of T's initiative in moving forward in a positive direction, but you also mentioned your experiences from back in your medical school times, how values and beliefs were different back then, and they're definitely changing in a more of a positive direction, but maybe we need to focus so that it the pace accelerates a little faster. Yeah, we can address this. I do have a question, if you don't mind. So you did mention that you did not face any, or you did not feel like you didn't face any microaggressions. But is there any kind of specific experience that shaped your views on Islamophobia in medicine and kind of moved you towards addressing them and advocating for those that side of thing? Is there any kind of specific experience or just in general, how did you move to advocating for Islamophobia? Yeah.
Yeah, and so again, I have to say that I have not felt that I've been on the receiving end, and it may be so. In fact, to be very honest, it's been quite the opposite. I've had so many patients say to me that, because you practice your faith, I feel I'm well taken care of. I've heard that so many times. But of course, there might be patients out there who are not coming to me. That's very possible. But I've not I've not experienced anything. In my other work that I do with the University of Guelph, I sit on the multi-faith resource team. And there I've heard from students more so, being on the receiving end. So I think that's really what's pushed me more towards this kind of work. And again, thank you to both of you and the Pure Medical Foundation, because it really opened my eyes. Like when I started researching for this, I came across, the Medical Advisory Council of Canada and, the CPSO article, and, it really brought to light that, yeah, this is, and so in my heart, I'm thinking, okay, I really actually want to embark further on this journey and so I have medical students from McMaster. And I'd like to, so up until now, I've done more of obviously the clinical training, but I think I'd like to embark further on the diversity and equity training, because that is so missing. We like I said, right off the bat in the first few sentences of my talk, that we don't talk about the religious diversity. And particularly Muslim women are targeted. So.
Thank you for that. And I do have a final question from my end. And Fatima, if you have any, you can answer after that. I do have a question. What kind of practical advice would you give to healthcare workers who want to embark on this journey or want to be allies in combating Islamophobia? What kind of first steps they can take to address this?
Yeah, and like I said in that slide, honestly, ask, be free and open-minded to have the discussions, right? I think it stems, I like to believe that people are good people. Most people are good people. And there's just a lot of ignorance and a lot of, in Canadian culture, we say that religion and politics are taboo. We don't talk about them, right? We'll talk about the weather or sports or whatever, but I think it's time that we start having those discussions and conversations. When my kids were little and they went through grade school here, I live and work in Rockwood, which is a very small town in Ontario. And so I would make it a point to have the conversation. I'd bring to the classroom or to the teachers or to the parents just conversations about Ramadan. Why do we fast? Or, prayer times, or, just different things, what do we eat, or that kind of thing. And I would often hear from parents afterwards saying, thank you so much. It instigated a conversation at the dinner table that we wouldn't have otherwise had. And so it starts, in a nutshell, in one word, it starts with conversations. Just have that conversation with your patients, with your colleagues, with your healthcare workers, with your friends, with your neighbors. It's just so worth it. And I myself, I'm having those conversations, and like I said, in the multi-faith work that I do, and I'm learning about other religions as well. So it's good all around.
Thank you very much. That was an interesting take on how we can, be able to tackle this in our, in a practical level, because life does not just end with a workshop, right? We have to implement that on a daily basis, and sometimes it's really like it may seem like it's easy, but like it's steps that we have to like intentionally take. And thank you for your take on that. And that's all from my end. Yeah.
Thank you so much. Yes, thank you, Sukrtika, and thank you so much, Dr. Khan, as well. It was just so wonderful to hear about, your experience, all of the beautiful, truly, you really brought in all those examples, all those statistics as well from like a personal viewpoint. And it is just first of all, inspiring as well to see, the work that you're doing as well, and how, you made it such a great mission of your career as well, to inform, future physicians, current physicians, and patients on, what they should do to, little pointers helps there when, dealing with such a situation. So honestly, thank you so much. You truly brought so much knowledge and so much expertise, and of course, kindness to our workshop by being here today. And so sorry, yes, I did have a quick question as well, Dr. Khan. My main question was this, given that, myself and Sakritika as well, as future, hopefully aspiring medical students and, wanting to go into this field, I wanted to ask that in regards to this workshop, do you find that your training in medical school and, just even prior to becoming a physician, on the job training, etc., do you find that they were able to, how shall I say, kind of introduce this topic or prepare you in any way for how to handle such situations? Because I know that's like a very open-ended question. So basically, I know that in medical school, there are often like certain courses that, aspiring physicians have to take on, like how to, for example, handle, like a situation, public relations situation, etc., with patients. So do you think that there was, even briefly any training on how to do so? And if not, do you think that it would be a valuable component that should be added as perhaps a medical school, course or within the curriculum somehow, so that not only for, like Islamic faith, but to prepare physicians to handle any such situations for any faith, for that matter, and so that they know. Sorry, I know it's a long question.
No, but it's a great question. Thank you, Fatima. And I actually remember, again, the very first day at Queen's Medical School, the dean came and he was a general surgeon, older fellow, had his, biases and opinions, and he pretty much said to the class, I don't know what the figure was, but he mentioned a figure, this percentage of you are going to fail because, medicine is hard and the training is hard and, takes a lot of grit and a lot of resilience. And in my heart of heart, I thought, no, I've got my faith. My faith is going to get me through. And it really did. I had my community. Besides my medical student friends, I had my Muslim students, and really, honestly, they had become my family. So back then, again, in 1994, there was no such training, unfortunately. You had to kind of swim on your own. But now I would like to believe, again, thanks to the work that you're doing, that tides are changing, things are changing, the horizon is changing. And this is really making me think that I'd like to, go back to McMaster, for instance, and start to engage with them about exactly what you pointed out, that not only the training of, and because we do get a lot of training about how to have difficult conversations with patients, but also incorporating that faith-based training as well. So yeah, thank you again for both of you.
Thank you so much, Dr. Pando. That really answers the question so beautifully. And we have no doubt with, fantastic physicians like yourself, that are, really spreading awareness to this cause as well. We have no doubt that hopefully even by the time that we're, in the same shoes, we'll hopefully have so much knowledge as well. So thank you so much. Thank you.
You're welcome, and good luck to both of you.
Thank you very much, Fatima, as well, for your take. And I just want to tell you that we had like an interactive session planned out, but because of the lack of time, and we will be focusing on this for our next workshop, because that's the focus of our next workshop, which focuses on the strategies and actions that can be taken to tackle this. So we will be focusing on this for our next workshop in the series. And meanwhile, to our audience will be watching this, sign up for our mailing list to be the first one to hear about our upcoming workshops. And this link can also be found on our Instagram page, and also our website that have amazing resources for both the patients and providers on various topics that target, immigrants and other marginalized populations. And we have so many great resources that we have designed for LGBTQ plus healthcare and racial equity. So please feel free to check them out and educate yourself, and follow us on Instagram, Twitter, Facebook, LinkedIn at Pure Medical Foundation to stay up to date regarding the upcoming events. And we're so excited to host those with amazing guest speakers like Dr. Khan today. And these are opportunities where you would be able to learn about various issues and health disparities that is in all around the world, but specifically in Canada as well. So yeah, that would be it for today. Thank you, Dr. Khan, for your amazing job. And I'm just going to stop recording so we can.